Our next speaker, I would say, our featured speaker, and you may have heard this expression before, but has forgotten more about transportation than I'll ever know. I think this is really where that fits. Sheryl has been involved at the Community Transportation Association of America for a number of years and the National Center for Mobility Management. She is one of the people there that I know I can always reach out to, because if she isn't already working on it herself, she knows who is and can get answers for us and help engage in conversations that are important to issues that we're discussing. So I was very happy to get Sheryl here. She got in yesterday and caused, I believe, the weather to break from 90s down into the 70s, so we're appreciative of that too. Her biography is in your folder, so I'm not going to read the whole thing, but we know that there are a lot of things she could talk about. What I've asked Sheryl to address in this morning's presentation is non-emergency medical transportation. What issues that she sees and the CTAA sees, what things are on the horizon that we all need to think about, good examples of things that people are doing that we might want to either emulate or consider for our area. So at that I will leave it up to Sheryl, and please welcome Sheryl Gross-Glaser.
Thank you very much to Terry for inviting me out to Iowa. I'm really honored because as a state you do such great work. You're really in the lead, and I'll go into that a little bit more later. If you want to interrupt me at any point, if you have a question, don't wait till the end. Just either raise your hand or shout out. Totally fine. I'd rather see people interested than like dozing. Be careful, you're being taped. As a former criminal defense attorney, I'll just say if you say something like I've embezzled $10 million, that is a legal admission, so just want to advise you against that. So I'll explain just a teeny bit now about CTAA. I'm going to talk about that a little bit more in the afternoon. I do work for the Community Transportation Association of America, and I've been there for a little under 10 years. I work at 2 technical assistance centers that CTA partially staffs. One is the National Center for Mobility Management, and the other one is Transit Planning for All through the Department of Health and Human Services. NCMM is funded by Federal Transit Administration, so if that helps. And then I also sort of have a subspecialty in autonomous vehicles and sort of emerging business models, ride-hailing, microtransit, that kind of thing. So I've got to admit that I avoided the whole issue of non-emergency medical transportation for a very long time. I'm uncomfortable personally with the whole topic, and not because I don't think people should be getting to medical care. Obviously, we all want people to get the care they need. And so why am I uncomfortable? I'm uncomfortable for a few reasons. One, because it's not part of sort of a general transportation system where it's single use. So I really had to question myself, so why is that bad? I have nothing against school buses providing transportation. I think it's great that, in Silicon Valley you have all these companies providing their fancy buses, from San Francisco out to wherever to shuttle their employees. So why am I uncomfortable with life-saving transportation? And I realize that it comes down to a couple of things. One is that if you're getting non-emergency medical transportation, are you then only getting non-emergency medical transportation and then not having access to other things like grocery shopping, like adequate number of trips to your pharmacy, to not getting to church, to see friends, to be able to get out somewhat. It's both a big problem and it's an indicator of a larger problem, which is being a second-class transportation citizen, essentially. I think as Americans, generally, we have two types of discomfort that we see when it comes to non-emergency medical transportation. The first goes back to the very writing of the Constitution, which is what should be controlled federally, what should be controlled by states, and then even within states we see so much variety in terms of state versus local balance. What do counties have authority over, or cities versus the state? And there is every permutation across the country. You know, some states being controlled by two legislatures and the governor in my home state of New York. I really hope this doesn't go viral. And you know, states where it's basically city-run and the state as a whole doesn't, I won't say do that much, but doesn't exercise responsibility as much, that things are much more locally based. And so it's very hard sometimes for us at CTAA to come out and talk to people in different states, because we know the national level very well, and some of us know particular states very well, but there's so much variety that it's hard to be an expert in everything. And so going back to the founding of the beginning of the Constitution, we see in the state constitutional conventions that approved the Constitution the same kind of political differences that we see right now. This debate about federal power versus state power, and should we have important things controlled, centralized in Washington? Then it wasn't even Washington, it was just, you know, state. I think the national capital was in Philadelphia at the time, but that idea of federal control versus state control versus even more local control. So we see that being played out even in the last few days in the current healthcare debates. The other thing that I think we're very uncomfortable with as Americans, and I think it's pretty much true whatever part of the political spectrum you're on, is this idea that we want to help people, we want to empower them, we want to provide them care that they need, but we don't want to make anybody too comfortable not being self-empowered. On the other hand, we have people who are they're very frail, maybe because they're older, maybe because they have a medical condition, maybe because of a very significant disability where they're never going to be able to take care of themselves. And I think we are all concerned that we as a country, as states, take care of them, but we're always fearful that people will get dependent on maybe different kinds of assistance and services that they won't then become self-empowered. I don't think we really necessarily have that, but I think we're all sort of afraid of that, and that comes into play with things like non-emergency medical transportation. So those are just things to sort of let marinate in your mind. Of course, they don't get your vehicles out every day, but I think they form the basis of a lot of different types of human services, medical services, etc. Another reason to be uncomfortable with non-emergency transportation is it straddles two kinds of programs. One is transportation and how that's handled at the federal, state, local levels, and the medical system and how it's regulated, which is very different. So you have two systems that are not really matching. It's like and I may be getting this wrong, the round peg in the square hole, or the square peg in the round hole, whatever, but they don't really fit that well. And I'm going to be talking in a couple of minutes about the regulations from Health and Human Services through the Office of the Inspector General that everybody's always fearful about, the anti-kickback regulations and how, what that talks about in terms of transportation. But you have a system on the medical side that's built around individuals, paying for individuals, and preventing fraud and abuse. And then the transportation side, where you're putting two pennies together, you're rubbing them, and you're trying to produce something, generally in a more systemic fashion, and trying to fit in without getting into trouble with these laws and regulations that are kind of scary at the federal level. And I'll throw in, since we're going to get complicated very quickly, hopefully not. Well, it's somewhat confusing, but hopefully not too bad. The complication that you should check to see whether Iowa actually has a law that's pertinent in this field, which may differ somewhat from the federal, may require more. So you don't want to get into trouble there. And I'm going to step down for 1 second and look at something, because I want to have you sort of marinate another thought as we're talking. So a question I get from time to time before we get deep into the weeds on the OIG stuff is, what is the value of non-emergency medical transportation? And how do we express that value to our partners in healthcare, our potential partners, to healthcare systems, to show them that they really need to be invested, not just financially, but as full partners with transportation. So I'll give you good news, and I'll give you not so much bad news as we lack a lot of data that it would be really helpful to have. A recent study was done that really went into, and I'll do I always like the bad news first before the good news, so that we end up on a little better note, because the bad news isn't terrible. But it's good to know what we know and what we don't know. So what we don't know is one missed appointment. The value of that missed appointment is not necessarily equal to the value of every other missed appointment. If you take a dialysis missed appointment where maybe that person has been leaving some of their appointments early, and then they miss an entire round of dialysis, the value of that is very different from maybe I'm missing one test to measure a blood level that's been going pretty well. So I miss it, and it's 90% chance it's all going to be okay. I come in next week, it's fine, versus the dialysis patient who then is significantly increasing the chances of a hospitalization and complications. And we don't have data on, okay, who exactly is missing the appointments, and what is the value of one kind of missed appointment versus another. Second, we don't know why people are missing appointments. We presume that transportation is a big barrier. Sometimes we know from anecdotal evidence that transportation is a big reason why people miss appointments, but we don't have great data, at least on a national level, of why people are missing appointments. And then third, people aren't always questioned about why they're missing appointments. So you have a medical office at a hospital, at a doctor's office, at a physical therapist, at a dialysis center, wherever, right? And they're busy. And generally, they're not asking, if you say, I have to miss an appointment, if you even call, why are you missing the appointment? So they're not entering that important data that would be so great to have. And if you're missing the appointment without even calling in, then they really don't know. And sometimes they're then losing track of you as an individual, may not even be following up with you. So that's the bad news. The good news is that even if we make conservative estimates, it's easy to see that the missed appointments have a large value and that transportation has a big place in that. So I'll just quote a few tidbits of information for you to think about. So one study has said that NEMT would save as much as 1/3 of ambulance costs because people without transportation will then call an ambulance, and it's much more expensive to use an ambulance than to have a regular NEMT ride. Another study says the cost to rural communities in particular of missed medical appointments is equal to from a little over $4 to almost $7 for each dollar spent on non-emergency medical transportation. So that $1 that's spent on non-emergency medical transportation is saving somewhere in the neighborhood of $5. So that's something for our medical partners to know, that they're not going to get a lot in return, but they're going to save a whole lot of money investing in non-emergency medical transportation. Another study did a very conservative estimate, and that's a study out of Florida. And what they said is, even if we look at 1% of non-emergency medical trips and make a guesstimate that we're saving one emergency room visit, the return on investment is a little over $11. So even if we're not talking about the entire universe of healthcare services and what we're saving, just in terms of those emergency room visits, if we make that very conservative estimate, we're saving so much money. I would guess, and don't quote me, don't go viral on this, that it's probably more than 1%. 1% is, I think we can all say, a very conservative estimate. And then before I go on to the OIG, since we're talking numbers just a little bit, that 3.6 million number, have you all seen that 3.6 million number? It's like quoted everywhere. Anytime like news organizations or blogs talk about how many people are missing medical care due to transportation, they always say 3.6 million because there's a study that was done, I believe, over 10 years ago. This one study that said 3.6 million Americans are missing medical care due to transportation. So number one, it's an old study, so it's an old number, and we don't know, is that really a very low number? Is the number much larger now? And you would have a feel for that if you've been in this field for the last 10 years. If that problem has been actually growing worse, then it's probably an underestimate. It also doesn't reflect, because it's a national number, it doesn't reflect what's happening in any particular state or in any particular county. So I always have a great skepticism when it comes to those numbers.
So Sheryl, are they saying that's a daily number, yearly number?
That was a yearly number. So when you see it, and you know, maybe you'll notice it now because I'm pointing it out. Sometimes, you know, that happens. I would take it with a large grain of salt because it's not a current number. The other thing, so, is are the patients being reached out to versus waiting for them to express a need for transportation? So just things to percolate, and I'll go back to them. So getting into the weeds now, the legal weeds on the anti-kickback statute. I hope you'll stay awake because it's important, but on the other hand, it's one of those things where it just gets into details very quickly. First, take a deep breath because it's all good. The Office of the Inspector General, OIG's office at HHS, which is sort of the controlling partner in all of this, has a very positive attitude toward transportation. They uniformly find ways to approve of transportation, to try to figure out ways to make transportation possible. But again, they're working with these statutes that Congress has passed and they have to follow, according to the law. They can't just say, don't really like that. They really have to follow them. So they're finding a way to fit transportation in and to recognize the need for transportation, and also recognize that when it comes to fraud and abuse, which they're trying to prevent, that they're not seeing much in terms of non-emergency medical transportation. Usually when you see the reports that refer to abuse, they're usually talking about ambulance stuff. That's usually more involved, or record keeping comes up, and but in terms of just transportation and who needs it, and let's have a program, and does this program fit within the law? They're very positive about transportation. So there's two statutes. We'll knock one right out of the way, the Stark Act, because that applies to physicians, their immediate families, and designated health services by Medicare and Medicaid. That's a strict liability statute. So strict liability means that your intent doesn't matter, and it's a very strict legal standard, but that's a very limited universe of actors that it applies to. What you have to worry about, or at least be cognizant of, is the anti-kickback statute. And I'll just read a little quote here. It prohibits the exchange or anything of value, basically, that's actually my interpretation, in an effort to induce or reward the referral of federal health care program business. And it is a very low bar. Basically anything over the value of like $10 per act, or $50 over the course of a year. So it's nothing, right? You're ferrying somebody 10 minutes and it's over, a trip more than 10 minutes, and that's probably a conservative estimate, and you're spending more than $10. So you can just assume it applies. And it's meant so that doctors, so that healthcare facilities are not, I'll use the word very broadly, bribing people, right, to use them. So they're not getting valuable freebies, right? And transportation could be a valuable freebie. If I have Dr. X who's providing a limousine ride with champagne to my office, that's a big inducement versus Dr. Y who's not providing any transportation. And you'll often see in the OIG office opinions and their rules, the word limousine tends to come up sometimes. I think it's just this sort of generic luxury transportation idea that they really want to emphasize is not allowed. But I don't think any of us have to really worry about that here. So, when you go to the pediatrician gives out stickers, or they give out like little rewards to kids right after their appointment. They're not talking about that. That's, very cheap little thing. So that's, okay, that they're not getting into trouble for that. But, anything, I would say, I don't even think you have to use the word significant, really becomes troublesome for them. There's criminal and civil penalties for individual and entities on both sides of the transaction. So that's the transportation provider, that's the healthcare entity that is putting money into a transportation program. So the good part about that is your interests align. If you're both partners in this endeavor, then you both have the same legal interests, which is good because hospitals and healthcare systems have lawyers, and they tend to be prudent. I'll use the word conservative, not in a political sense, but in a, sort of that small c. They don't want to get into trouble. So, so that's a good thing. Now, some intent to do ill is required, but you don't need to know knowledge of specific legal provisions. So you can't say, well, I didn't realize the champagne in the back seat was a bad thing. I didn't know that the law prohibits that kind of thing. That's not an excuse. It's kind of like saying I've never read the law that prohibits, you know, murder, right? It's not going to get you very far. So the nature of the legal system and the players involved. So Congress passed these statutes. Health and Human Services has regulations that the OIG's office, through their regular administrative process, has, I won't say passed, but has created. And then you have the OIG advisory opinions. So the OIG advisory opinions are basically the requests for information. You have a specific transportation program that your healthcare system is contributing to. I'm not talking about public transit where there's a bus stop at the hospital, but, you know, a non-emergency medical transportation system or a specific healthcare shuttle kind of thing, right? And they just want to make sure that that arrangement is kosher. So they'll request the Office of the Inspector General to look over the arrangement, and then the OIG will offer, you know, almost, it is a legal opinion. Now, those legal opinions always say, beware, disclaimer, basically, this only applies to this situation, and if anything is happening outside of the four walls of what we've been told, then it doesn't apply. But on the other hand, you will see people from that office, when they do their presentations, basically say, well, you can look at these opinions and know what's allowed and what's not allowed. So technically, there's no value in terms of precedent in those opinions, but I think they're really, you know, they're basically saying there is. In December 2016, so that's less than a year ago, OIG, after 2 years after they had a proposed rule out, they issued a new rule. So I'm going to go into the details of that somewhat and then talk about some advisory opinions. And again, it's all good. But, and I say BUT in capital letters, it's again, it's that square peg and round hole that don't quite fit together, that they're trying to fit together because they know that it's a big problem. In fact, the greatest number of comments they got to their proposed rule was about transportation. And they're well aware it's a big issue, and I think if they could, they would be knocking on the doors of our congresspersons' offices and shaking them up and saying, really, can you help us? But that's not really their role to do. But you get the feeling, looking at all this stuff, that they want to make it right. So this is what they've done. They have a rule, and basically it's two types of transportation that they've created these the safe harbor rule for. Safe harbor meaning kind of exception. You don't have to worry about it. That's the best way to describe it. One is for shuttle service, and I'll talk about that second. The second is transportation that would just be for established patients, so not applying to caretakers, family members, or visitors. I'll talk about that later when it comes to the OIG opinions. And let me just state that you shouldn't have to have a law degree, but it really helps looking at this stuff because you just have a sense of humor about it when you have that framework in your mind, which is that words that are used do not necessarily mean what they're commonly used for in normal, everyday conversation. And that I don't find too frustrating. I find it kind of humorous. But as a regular person or somebody who's trying to follow the law and create a program or provide transportation, must be very frustrating because you want to be able to read a rule, you want it to be clear, you want it to be easily understandable, and yet you really have to read it as though things don't necessarily mean what they say, and that you always have to go to the definitions, and then it becomes very, it feels very complicated, which is unfortunate. I could talk for an hour about why that is. I'll just say very quickly that the law very much relies on terms of art, right? You have a word. This word has been used for a long time. Everybody in the field knows what it means. And so even if language has moved on or common language doesn't mean the same thing, because you've kind of well-defined that word legally, it's just easier to move it forward and use it. So the first word we're going to visit is established. So the safe harbor rule applies to established patients. When I think of established, I think of a regular patient, right? I've been going to this doctor or to this healthcare facility, to this physical therapist for a while. That is not what it means here. It's pretty much the opposite. It's anybody who's made the first appointment. So you pick up the phone or you email the provider and you're not an established patient, but you make the 1 p.m. appointment on Tuesday. You've never seen the medical facility. You've never spoken to the doctor or the therapist or whoever. You are considered an established patient, even for purposes of traveling to that first appointment. And again, that kind of shows where the OIG is on this. Another word you should be careful about is local. So I think of local, I'm from New York City, so I have a different definition than other people. I think of like the next 5 blocks. Somebody might think in terms of the next 2 or 10 miles. Local in this context means 25 miles. I'm pretty sure nobody ever thinks of local as 25 miles, and that's not in rural areas. So in a rural area, it's 50 miles, which gives you a lot of flexibility in terms of transportation, but if you're just looking at the rule, yeah, I have to look at the definition because it doesn't comport with reality or the way we actually talk. And where are you defining, what's your determination of what's local in the 25 mile versus 50 mile? So it's where the patient lives. So if you're going to University of Iowa Hospital in Iowa City, I would assume that's considered an urban area. That's not what you're measuring from. The person, the patient, is starting out in a rural area, so it's 50 miles. So they have that leeway of 50 miles if transportation is being provided.
And how is rural defined?
Oh, that is a great question. And I don't think I have that in my notes. I have that, let me look. I have that on the CTA website because it's not a Department of Transportation definition that's used. It's a definition, I believe, from the OMB, Office of Management and Budget. So it's urban, rural, and New England. New England has like some special designation, but you're outside the Northeast, so you don't even have to worry about that. As long as you're out of Red Sox Nation, you're good. So if you're getting into the real weeds of like, am I rural on this street versus that street, you have to look at that definition, and that's on the CTAA site. If you want me to get in touch with you about that after, bug me, come over to me and I'll write it down. And feel free also to send me an email and say, I had this question and you didn't answer it, okay? Because once I travel, things get lost. So even if I write them down, because there's always stuff, but really, feel free to shout out It's always better to bug me by email or text rather than a phone call. So generally, so we talked about limousines, no luxury transportation. Whether you're talking about this new rule or you're talking about advisory opinions, we're not talking about Sex in the City. Mr. Big had his limousine, right, where he went everywhere. We're not talking about that. On the other hand, even though air travel would be considered generally luxury, if you're like in Alaska, I always use Alaska because it's a great example of this. In Alaska, you have a lot of places without roads. The only transportation you have is air. So it wouldn't fit within this rule, but there's a good chance that OIG would say yes to it. Other general rules are not advertised or marketed. I'll get a little bit into that more because that's really a gray area. I mean, they use those terms, but it gets murky. And transportation is not claimed under any federal health care program directly or indirectly, which is kind of crazy from a rational point of view, because you would think that as the insurer-in-chief in terms of Medicare, Medicaid, that you would say, okay, maybe it's a good thing if we provide transportation, but okay. So the two types. So we have direct transportation, basically demand response for established patients. Again, that doesn't include anybody else, but that doesn't mean outside the rule that you can't do that. But if you're fitting within this rule, you're talking about just that transportation, and local within that expansive definition. It also applies to shuttle service, which is another thing which you could spend hours on. And the rule is not that long, but the explanation of the rule is over a 100-page document. So shuttle service versus sort of transit service. So a hospital system says, okay, we're going to design this shuttle service. We're going to put our dollars into it. It's going to be a 25-mile route. It has to be, to fit within their definition, fixed route on a schedule. So already the OIG's office is behind because they're saying it can't be any kind of on-demand, like an app-based or a call-in based, right? If I call in and 5 other people in my county are calling in at the same time and saying, I have an appointment in an hour, can you get me there? And you have a van and you can pick up all 5 people and take them at the same time, that doesn't count because it's not fixed route, it's not on a schedule. Again, it doesn't mean it won't be allowed. I'll go into that after, but it means it doesn't fit within this rule. So within the rule, there's this nice, almost like parallel universe. It's fixed route, it's scheduled. This means they're allowed to do it. No hospital, no healthcare system is required to do this. It means, okay, we're going to set up these rules where you are allowed to do this. So you set up a route. Who is allowed to get on the vehicle? Basically, anybody they decide can get on the vehicle. It can be for the general public, right? So let's say you're going from Cedar Rapids out 25 miles, and we're going to set up this one route on a schedule. We're going to have vehicles every 10 minutes. We're going to stop at the grocery store, at the pharmacy, at schools along the way, at major employers. All fine. That's totally legal. It can be free. Anybody can get on. They don't have to be going to a medical appointment. They could be going to the coffee shop. Maybe they have a heart condition where they're not even allowed to have caffeine. But if you've set up this shuttle, they can get on the shuttle. They can go have their caffeine, and then they'll have to make their medical appointment. That's totally fine. Or you can limit it to employees. You can limit it to established patients. You can limit it to patients and their caregivers. You can have a shuttle that's only meant for visitors. But if you're going to limit it, in theory at least, you should be checking right who's getting on the vehicle. So I'll give a nice example of my own illegal conduct. Hopefully this won't go. I don't think actually I'm the illegal player in this, so I think I'm good even if this goes viral. So I had a friend who was in the hospital in Baltimore for about 5 months. In Baltimore, depending on where you're coming from the DC area, so you're talking 45 minutes to an hour. And often I would go up during the week and I'd work at his bedside, especially when he was in this sort of, I'm not sure what it's technically called, but it's basically, medically induced coma for a while. So I'd go up and I would just spend the day and I'd work, and then I'd mention all this stuff about work to my friends, since basically, I don't know if you could hear it or not. So I'd take the train up. And at first I was taking a taxi from Baltimore's Penn Station to Johns Hopkins, which is about 10, 15 minutes away. And that gets a little expensive. So I asked somebody, well, is there another way to get from the station to the hospital? And they said, sure, go to the corner, there's a stop, and you just get on the shuttle, and it takes you right to the hospital. And indeed it does. It was less than a half block from his particular building at this huge hospital complex. It was only when I was researching this topic and looking online for this great example that I saw that actually it's only for hospital employees. It's not for the general public. And no one ever stopped me. Nobody ever asked or even seemed to look at IDs. I hope Johns Hopkins doesn't get into trouble on this, because it's a great service. There's about 3 or 4 stops on the way. Not that many people get on. Most of the people get on either at the beginning or the end. It comes like every 10 minutes. It's this great thing. So I enjoyed using it for many months. So, but they were, that's a perfect example of how you could do a shuttle service. Because when you look at Hopkins, it's kind of off to the side. It's not in downtown Baltimore. It's not near the Inner Harbor. So places where people might be able to get to pretty easily by transit, they're kind of out there. But it's a great way for a healthcare system to say, okay, what are those social determinants of health? That's very healthcare friendly language. And how do we support people being on the positive side of those social determinants? We enable them to get to all the places they need to get to. We make it easy. So in theory, you could have a shuttle service from Cedar Rapids to Iowa City. And I'm going to get really bad now about my geographic knowledge of Iowa, to Davenport. And you have that radius. So the radius is 25 miles or 50 miles, depending. Now, OIG isn't thinking about, well, does somebody have walking or biking access? Probably they're not biking if they're getting a lot of health care, but that's a different story. But do they have access to the shuttle service? But in theory, they are allowed, a hospital or another healthcare provider or a set of healthcare providers are allowed to invest in this kind of service. And the other thing is there's a lot of leeway for them. So I'm XYZ healthcare system. On one's, I have my hospital, my set of doctors and other providers. And here I have ABC healthcare system with my own parallel universe of healthcare facilities and providers. As XYZ, I'm making a big contribution to transportation. I'm setting up this great shuttle service. We're going to all these different places, but we are not stopping at any doctors, any hospitals, any physical therapists, etc., associated with ABC. They are allowed to do that. Now, I'm just saying this generally. You really have to get into the weeds, which is why it's nice that healthcare systems have lawyers who have a lot of expertise in this, because everything gets into like its own little rabbit hole of details. But generally, from a general standpoint, they could do that. There's not a lot of limitation, as there is with the established patient. So let's talk about marketing and advertising just for a few minutes. Because that's also an issue where I think the only way to put it is that, you know, it's irrational. It's somewhat irrational, right? You work with people every day who need to get to health care. You want them to know what their transportation options are. You want them to know where to find information. You want them to know what options there are. You want them to know when do they have to arrange, where do they have to arrange for transportation. I'm just gonna, right? So the rational sort of human thing to do is to presume that more outreach is better. But the regulations they talk about this new regulation, the advisory opinions, they all use this not marketed, not advertised language. And what does it really mean? I don't know. I'll be honest. What are the boundaries of that? What are the bright lines of that? I don't know. Because when you look at the language and you look at the explanations, it seems pretty harsh. You know, be really prudent about who you share the information with. And it seems when you read it, you would think, oh, don't leave it lying around. Don't have these brochures out. But there are places, even hospitals, that have approved having the information out. So they must feel pretty safe with that. You can read online about healthcare systems that have arranged for, you know, large companies like Uber and Lyft to provide non-emergency medical transportation. And here I'm reading it online. That seems like it's kind of being marketed and advertised. I guess those are gray terms. You can ask patients, and I think that's a really great thing to do, to say, do you need transportation? And not only ask them once, but ask them at every appointment, because just like health insurance changes, and every time you go into a doctor, they ask, you know, is your address the same? Is your health insurance the same? It's really good to ask, do you have transportation? Has your transportation situation changed? Do you need transportation? That's really a great question to ask. And in fact, in a survey, and I won't say that I know the details of the survey and how it was done, if it was done in the most scientific way, but the statistics is that 86% of patients, which is a vast majority, would like, when they arrange for transportation, to do it when they arrange for their medical appointment. So it's a really great point of contact. So when people ask me from time to time, well, what do we do with this information and how can we use it? It's really hard to give an answer because it's very gray, and the regulations don't give hard and fast rules. I would say you should do a few things. One, be consistent. The way you get the information out in one place should be the same as the way you get it out in a different place. You should get it out consistently to patients. So if you see somebody who's purple with white polka dots, you don't make a presumption that they need or don't need transportation versus seeing somebody who's wearing yellow with brown stripes and say, oh, that person needs transportation, right? Because we all do that. You know, the person wearing the sloppy t-shirt may be a multimillionaire, but somehow they don't look like it if they're wearing the big t-shirt. So it's better to be consistent, to have the same method of outreach across the board, and you're less likely to get in any trouble. And I wish we could stop recording right now, because I'm going to say something that probably is not, I don't know, 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 I don't know legally correct, but in our world where things can go viral, I think it's always something to keep in your mind. You're all providing transportation to people who really need it. And you know, the federal prosecutor comes knocking on your door and says, you know, you've left that brochure out in the hospital waiting room and we're coming to get you, you know, where the indictment is coming, right? By the end of the day, you have that patient, that sympathetic patient who needs transportation, and you have that video of that person on the vehicle explaining what a life-saving service this is, right? And the nice driver who's providing that service. I can't imagine that prosecutor can, you know, face that down if that goes viral and goes on your local news and everything. Not that I'm recommending that. But in this day of viral, I can't see that happening. And what they really want to get at is the real fraud and abuse. So they're not looking for, you know, the brochure that's out in the lobby versus, well, you should be handing it out carefully. I don't think that that's their target. Yes?
When you're talking about these rules, are these Medicaid rules or FDA?
No, they're OIG rules, Office of the Inspector General.
So they apply to everybody, even if you're not using any federal money? It applies to that, or who do these rules apply to?
Right, it applies to that. And they're not supposed to be using federal money. They're not supposed to be using Medicare or Medicaid dollars for this, as opposed to Medicaid transportation. As opposed to, and I'll get even more confusing. So, you know, as an example, there's a fare-free transit system that operates in an area that borders Vermont and New Hampshire. Their hospital is a major sponsor of the transit system, but they're not providing healthcare rides. It's not considered like a healthcare transportation system, so they're not in the midst of these rules. So there's a lot of weeds, and that's one way to, I won't say avoid this, but to really think about the whole issue a little differently. So does that help at all? So if you're Googling, sometimes the OIG website can be a little difficult to navigate. It's usually better to use Google to get into there. If you have trouble, you can bother me. When you look at the advisory opinions, you look at them by year. You can't always search them just like through the archives through the years. And then you're getting a lot of ambulance and, you know, other stuff in there. So it's not the most friendly website, but that's where the information is housed. So getting to the advisory opinion. So that's, you're talking about anything beyond that rule, the shuttle service and the established patient rule. So you're in a rural area and you're providing transportation 52 miles out, right? So you're beyond the 50 miles, you're beyond the rule. Or you're providing transportation that includes caretakers or others, right? You have a mom, and the mom needs medical care, or her kid needs medical care, and she has 2 other kids, so they're coming, right? So that's not just the established patient. It's not on a shuttle. It's beyond the rule. You have a nursing care facility, and you want to help visitors get there, or employees get there. That's beyond the rule, as long as it's not the shuttle, right? So we're clear. So once we're beyond the rule, you're looking at the advisory opinions, and I'm sure that's exactly what you want to be spending your time in, is reading through these opinions. So hopefully, excuse me, I'll be able to at least clarify. And again, the news is good. The OIG, the the feeling you get out of all of this is they want to approve transportation. They see how important it is, and they're trying to read their rules in a transportation-friendly way. And they get to that same answer, which is yes. So I'm just going to describe a few situations in which they've said yes. Not to say that there'd never be a no. Again, we don't want the limo with the champagne. That's definitely a no. Okay, so the most relevant one is one that came out, one opinion that came out about a year ago. And it talked about something that I think is pretty common in places that do have good coordination, like Iowa. So coordination among districts was involved. Transportation subsidies with patients with financial need. There were healthcare districts that were subsidizing the cost of public transportation as well. And there was a mobility manager that was being funded, essentially. It wasn't called a mobility manager, but essentially that's what it was, to educate patients about transportation options, to do transportation travel training beyond services that were in place, compiling a database of options, eligibility, costs involved, all of that. And the OIG said, yeah, great, this is fine. Obvious that this is a needed service. There's no money being wasted. It's good, all fine. But to give you just a few other examples, agreements among government entities for NEMT within a county, they've approved that. Transportation for friends and family to visit nursing home residents, they've approved that in a given situation. Transportation and accommodations for high-risk pregnant women as they got closer to their due date, that's also been approved. There's even been situations where it's been approved where you had visitors to a major medical center and transportation and hotel were being provided, and that's been approved. So they're really on the side of transportation being provided. But again, they don't have to. That's it's all kind of if they want to. Yeah. Are we good for time? Okay. So,
10 to 12 minutes.
Okay, so I have more to talk about in terms of some trends, things I see. But I'm happy to stop if anybody wants to discuss anything in particular. Okay. So what are we seeing? And I'm going to talk this afternoon about this. We're seeing a romance with a willingness to on the part of healthcare partners with on-demand, app-based companies. So I'll just say generically Uber and Lyft, but there's others out there. I won't go into the terminology on that. I'll do that a little later since we're short for time, but it's the idea that it's easy, and many of these involve call centers. So it's not just you need the smartphone anymore. These companies have gotten that message that if they're going to work with healthcare, they have to have a phone-based system in place as well. They are working with major medical systems and across states. So here we go. So Uber and an NEMT company called Circulation is working with 700 facilities across 25 states. Their no-show rate has gone down from 25% to 8%. St. Vincent's Charity Medical Center in Cleveland, they're piloting a project where they're connecting recovering addicts via ride, I'll call them ride sourcing services now, but Buffalo, New York is using a major medical system. They're providing free rides for Medicaid patients across their whole network. And there are others. I don't know if you've heard of Liberty Mobility Now or ITN America. And there are sort of homegrown, I'll call them sort of homegrown, more locally based systems that are in place to provide app-based, on-demand transportation. And they're cheaper. Why are they cheaper? Because they can be, the vehicles are being driven by people who aren't paid that much. They're driving their own vehicles. They're putting into place accessible vehicles, but the presumption is that most people don't need that wheelchair accessible ride. So they don't always need the wheelchair accessible vehicle. You could, in theory, even use volunteer-based for that. You know, you let's say have a number of volunteers who are available during, you know, a shift, and then they get that call. So it's not necessarily, it doesn't have to be a ride that's scheduled way in advance. And the hospitals and healthcare systems seem to be more and more comfortable with that kind of thing.
I was just wondering, for that Colorado example, couldn't that be construed as fraud for not charging Medicaid population for a ride, but you're charging for other services and or inducement?
I think that's a great question, and I'm sure there are lawyers.
Because I don't know if everybody heard.
Oh, okay, so the question is, well, why isn't that an illegal fraud or inducement to have the hospital having an arrangement with Uber, let's say, that we're going to give our Medicaid patients, if they need a ride, a free ride. And I will say to you, I don't exactly know. They're probably doing that legally through Medicaid and not through this system, which is not supposed to be only tied to Medicaid. Because Medicaid, right, if you're taking a Medicaid ride, that ride can be totally paid for. And depending on what state you're in and how it's administered, it may be a more patient-friendly service than in another state. Because Medicaid is really, it's a federal program with certain thresholds, but it's basically state by state. So whatever you have in Iowa is not necessarily what they have in Wisconsin or Montana or wherever. Yes?
So I was just curious about connecting the relationships between paying for these services. Now, do you see a trend for most of these healthcare systems to pay directly at contracting with the healthcare system or the healthcare system's foundation?
And I think that is a good question. I think it's probably mostly the foundations that are doing that. Like in the Fair Free Transit system. It's probably technically the foundation that is contributing the money. And now you're starting to get to the boundaries of my knowledge. Okay.
And because, do the OIG rules apply in the same way to 501c3s? You know, those foundations?
Right.
Who want to subsidize healthcare transportation, then does that apply the same?
And I'm going to tell you, I don't really know, but I suspect there's a difference because you do see those foundations contributing like to transit systems, which are outside of this. And I'll go even one more because I was speaking to somebody recently who was talking about partnering with, you know, Uber or Lyft or something like that. And they were saying they would only do it through a nonprofit, not through their governmental organization, because they felt that it was legally pretty risky for them. So you definitely, yeah, I mean, it's unfortunate, but you do want to have like somebody who is very knowledgeable about this look into it. The other thing that I think we're seeing more of is, and say more of, I'm not saying like everywhere popping up, but popping up in some different places, is the idea of sort of a holistic approach to the patient, which includes transportation. So, you know, that means having a healthcare navigator or somebody who does that kind of thing, where it's, okay, this patient is being released from the hospital, they feel like crap, and I would use a different word because I think that's how people really feel, but they feel like crap. They're going to feel like crap probably for months. They're probably in pain. They are probably on a few different medications. They are probably not getting adequate sleep because of the medications or the pain. Maybe they're living, you know, they're very isolated. And I would say the only way where we can really get into that patient's head is if we all say, all right, I'm not going to have more than 2 hours sleep a night for the next week. I'm not going to eat well. I'm not going to see anybody else or very few people. I think that's the only way for us to really understand how that person feels. And then we're saying to them, okay, you have to take it upon yourself to make the appointment. You have to take it upon yourself to arrange for transportation. You have to take it upon yourself to make sure somebody's helping you out in the house or helping out with groceries, right? This is not a good way to approach the patient. They're then very possibly not going to be taking care of themselves. They're possibly not going to be taking medication. They're not going to be well fed, well rested. Then they have a higher chance of missing those appointments, so then there's a much higher chance they're going to be hospitalized again, right? And that's not good. That's a pain point under the Affordable Care Act for the hospital. We still, you know, for right now have the Affordable Care Act. And the hospital, like any rational entity, doesn't want to pay more money. So what some of them are doing is they have these navigators who are not just concerned with healthcare, but they're concerned with that whole patient. You know, is that person being taken care of? Do they have access to what they need to have access to so that they can get better? And that includes transportation. So that's one route. Another route is, I was just talking to somebody in Indiana who the hospital actually approached a transportation provider, a nonprofit, and said, we need to get people to transportation. Will you do it? And the transportation is being provided to the hospital, to doctors, to dialysis, because the hospital system has seen this pain point. They're seeing that people aren't getting there, and in fact that nice little system, that program is expanding. And I kind of compare it in my own mind, and we all have our own perspectives, so hopefully my kids say I'm not the greatest at analogies, so I hope this is one that translates. So 20-something years ago, when I was putting my first child into preschool, I looked at all these different preschools, right? And they had different approaches. There was Montessori and Waldorf, and they were faith-based and, you know, very academic. I don't know if you can go academic in preschool, but ones that had a more academic focus. And, you know, I went to like 500, that's an exaggeration, but I went to a whole lot of preschools, and we would spend 2 hours, and she would play, and I would look at the teachers and what was going on. And I came to the conclusion that it really didn't matter what the philosophy of the preschool was, that it was just, were the people there committed and really actively engaged in what they were doing? And I would say the same is true for transportation. So here we have one model of, right, we're going to look at the whole patient versus, okay, people need X, Y, Z. We see transportation is one of those needs, and we're going to separately arrange for transportation or transportation information distribution, right? It seems less connected, but on the other hand, if you have people who are committed, who are doing a good job, it works. So I hope my analogy worked. The other thing that we see is outreach that's being concentrated on in different areas. And I think those are areas where there's already different transportation players, both public transportation, nonprofit, volunteer, and people don't necessarily know that services exist, right? I mean, you break your hip, you go into the hospital, you've always been driving, and you don't even know that there's stuff out there, right, to help you in terms of transportation, get to those appointments. So how are we going to make sure that people even know that all these pockets of services, you know, that serve maybe different kinds of people, or like the American Cancer Society. I know it's called something different here, but it's the excuse me?
Road to Recovery.
Road to Recovery, yes, that's what it's called nationally, and I know some of them have different names locally, right? So how do people even know that it exists? You don't know to ask the question unless you know that something's out there. So there's a few different places that have very good one-call, one-click systems. So a website and a phone-based system. Sometimes it's just sometimes it's just a phone-based system, where they've taken it upon themselves through local partnerships. And when I say local, it could be like a metropolitan area or a much smaller area, that has said, okay, we're going to actually have current databases of what transportation is available, to whom it's available, when it's available, that people can very easily either call up or go to a website, put in their information or tell somebody their information, you know, have the pertinent questions asked, and then figure out, okay, what are the actual options for me? So it could be a veteran. It could be somebody looking for employment transportation, or it could be somebody who is going to the doctor, the physical therapist, et cetera. And that would be one question. Are you going to, you know, healthcare? And so that brings in a whole different range of different options. So let's say you're going to the chemotherapy appointment. You're not staying overnight. Let's say you have a ride there, right? Somebody from your neighborhood can provide the ride there, but they can't provide the ride home. So you're looking for, you know, what are those options? Is there anything available to me? And I have a list of ones that I think are very good, and they are not easy to find. And that's, not all of them are easy to find, and that's a downside. And I'll be honest when I say to you, sometimes these things are set up by someone who's great, and they get the whole thing set up, and they're just like this maverick person. They've done a great job, and then somebody grabs them for the promotion or to go to a different organization, and suddenly the ball is dropped. And so you'll have something set up that's not really promoted or maintained as well as it could be. So the few that I like to recommend are there's one called Find a Ride in Lima, Ohio. It's a call center. There's no website, but there's information. And I think I put that on the handout. If it's not, bug me. There's one in Vancouver, Washington, and the surrounding area. It's called the tripresourcecenter.org. There's one in Jacksonville, Florida. It's called Transportal. So that's transport and an AL at the end. In Salt Lake City area, it's called Utah Ride Link. And in Atlanta, it's simplygetthere.org. And why do I even have to mention these? I mean, mention the names, right? We have Google. The Google machine is like amazing, right? You want to find out like who had the best home run record in 1935. And within 20 seconds, you have that information. But you want to get there to Simply Get There in Atlanta to go to this great website. And I swear, unless you know that term, maybe even if you know that term, you cannot get there through Google. You know, if you think, okay, one call or transportation options or whatever, you will not get there. It is very hard to find, and that is a downside of some of these, or an aspect where the ball sometimes gets dropped. And I think it's a really important, can I just go on 1 minute? I'm sorry.
1 minute.
1 minute. I think it's a really important thing. It's almost better if you have a service that isn't as good that people can get to very easily, rather than this like incredible website that's so friendly once you get there, but if people can't, don't know how to get there, or they can't get there really easily, then it might as well be the tree falling in the forest. So that's a really big issue in my opinion. And I'll be quiet now.
Please thank Sheryl very much.
Sure. Feel free to grab me or to send me an email. I'm around all day.
And we're going to a break now, so you can ask Sheryl questions if, while she catches her breath on the break. And it's a very difficult subject, talking about non-emergency medical transportation, because there are so many layers to it. The things that we're talking about are things that people have wondered about for years. Like, well, why doesn't a hospital just make a van service? They would save all kinds of money because they get people to their appointments, and their people would be healthier. People would love them more. I mean, all these things. But then you start listening to all the rules and what you can do and can't do, and you also then understand why a hospital doesn't just have a fleet of vans running left and right all over town as much as they might like to. It's a complicated thing, but we need to continue to discuss it because, well, one, as Rebecca mentioned earlier, you get people who might have a transportation benefit through Medicaid, and then they go to Medicare. Then what do? Then think about the other aspect of this. Every state, or a lot of the states, would love to try to get rid of that transportation benefit. Even ones that we live in. If they can figure out a way to not pay for those, they do it. And so then that can be another complicating factor. Then people who aren't on those programs, I get calls from all the time saying, yeah, I normally could take the city bus, but now after my injury, I can't. What do I do? And so there are a lot of complicated issues. This is part of what we'll talk some more about this later on and when I have my comments. But it's a very important issue, and we thank Sheryl for trying to outline a lot of it for us. But there are many questions we'll still have to address.